we've talked about a lot earlier on. And then one extra one that I'm going to put on there, because it relates to the research that I do, is something called failure to integrate. So I'm going to talk about that a little bit more when we get to that section. But these are the three main routes that people consider. So thrombosis is the main mechanism of vein graft failure within the first month after CABG. Okay? So that's within the first 4 weeks of having that surgery. If you get a failure of a vein graft in that time, it is most likely going to be because of thrombosis. And this is caused because you get damage to that endothelial cell layer. You remember with the endothelial cell layer, those were the green cells. That's the ones that line the inner layer of your blood vessel. And if you get damage to that endothelial layer, then that can lead to thrombosis. The ways that they can do this, one of the ways is through what we call turbulent flow. So if you have a blockage in your blood vessel or any kind of disruption to the shape of your blood vessel, when it's just a normal tube, your blood is going to flow through it without any trouble. If you get any kind of disturbance in it, when your blood flows over it, you can get some backflow. So it's not a smooth tube anymore. It means that you're going to get that backflow. We call that turbulent flow, which I've just put an example is this going over a waterfall here. And this can happen when you get a size mismatch between your coronary artery and your saphenous vein. So if we look at these pipes again, so if that's your coronary artery, it's not, that's far too big for a coronary artery, but just as an example for illustration. If that's your coronary artery and that's your saphenous vein, if you plumb those together, you can see that they're not going to match perfectly in terms of size. And so that area where they join together, you're going to get that turbulent flow because it's moving from a wider area into a thinner area. And this can happen in a number of different ways. Your coronary artery normally is between 1 and 5 millimeters. That depends whereabouts on your heart it is. So if you look at your heart, if you look at the red ones here, you can see they're very wide. So this would be where they'd be 5 millimeters. But you can see that they come down and they branch down into much smaller parts of the arteries, and they can be a lot thinner. Your saphenous vein, it says on average is 4 millimeter. Having worked on over 1,000 saphenous veins in my time, it varies massively. If you get a bit of saphenous vein that comes from the top near your thigh, it's a lot wider than the bit that you get down at your ankle. And it also is affected by gender as well. So that's just an example of what we put together there. You're going to get turbulent flow around this joint. And that turbulent flow can then damage your endothelial layer because it can be mechanically damaging to it. So the other way that you can get that kind of damage as well is through the mechanics of doing the surgery. I mentioned how that surgery is done. It's quite an invasive surgery. It's a very physically demanding surgery. And you can imagine if you're handling blood vessels, if you're clamping them, you're putting solutions through at high pressure, that can all cause damage to that inner lining, which is only 1 cell thick, if you remember, so it's very delicate. And what the surgeon does, particularly with the saphenous vein, but with the other vessels as well, after they've taken it out of your leg, they then have to tie off any branches, and then they have to push through high pressure saline. So they'll do that as a high pressure wash. And there's 2 reasons for that. One of them is to check for leaks. You don't want to graft something on that's going to leak. Okay? So they have to check that all the branches are tied off properly. And the other thing is to reduce spasm. Because what can happen with your blood vessels, because the smooth muscle is a type of muscle, and it can spasm and contract, and then that can block it as well. And by doing the high pressure flushing of it, it stops that from happening. But what that can do when you've got that high pressure solution going through it is it can disrupt your endothelial cells, and they can come off in the wash, if you like. And what happens then, if this is a blood vessel that's been opened out, so it's like this, and now you're looking down on that endothelial layer, if you get that high pressure wash, some of those come off. So you lose those smooth muscle cells, endothelial cells, and that exposes that underlying tissue. And because of this, there's been a development of something that's called the no-touch technique. And and this is a surgical method where the surgeons do everything that they can to avoid actually touching the blood vessels too much, which then makes it a lot less likely that they're going to undergo this loss of endothelial cells. If we look at how that causes thrombosis, so if we've got this, we've got lost some of those endothelial cells, which has exposed that underlying layer. What that can do is you'll get an increase, then of fibrin will attach to that. Fibrin attracts platelets, so your platelets become activated and they will attach to that fibrin that's been exposed through the loss of your endothelial cells. That then recruits your neutrophils, and that increases the expression of tissue factor as well. That triggers your coagulation cascade and get your red blood cell recruitment, and altogether that makes a lovely blood clot. Yeah? And that's how that high pressure distension and the loss of those endothelial cells causes that blood clot, which can block your vessel and which can lead to that early failure of your vein graft within 1 month. So the second one, neo-intimal hyperplasia. And you can break that word down, so neo means new, intimal means your intimal layer, and then hyper means too much, plasia means growth. So you get too much growth into that intimal layer. And that's the main mechanism of failure between 1 month and 12 months after CABG. So if you have a graft that fails within the first year, but you've got out of that high risk first month, then it's most likely going to be because of neo-intimal hyperplasia. And what neo-intimal hyperplasia is, it's a physiological role that's gone wrong. So as with a lot of things that cause diseases or disorders in our body, they start off as a positive thing. They start off as something that's there to help, but then they just go a bit too far, they don't get switched off in time, and then that causes a pathological problem. So the main way that they have this physiological role is because of the inherent differences between your arteries and your veins. So your arteries, your lumen diameter and your wall thickness is always at a constant ratio. So if you've got a large vessel, if you've got a small vessel, if you look at the ratio between your lumen diameter and your wall thickness, that's going to stay constant. And that's just an example here of 0.5 centimetres and 3 centimetres. It's just giving us an example. Don't go around thinking that all your blood vessels are like that. Your vein doesn't have this feature, and so your vein, what it does is it uses neo-intimal hyperplasia and smooth muscle cell proliferation to try and mimic that wall thickness. So it's trying to basically become more like an artery so it can do its job properly. And the time scale for this is that 3 days after surgery, you should have an increase in smooth muscle cell proliferation with that reduction in contraction. So I talked earlier about that phenotypic switch and how that phenotypic switch is important in disease. It's also important in recovery following injuries, such as cuts, and this is an example that would relate to that. So 3 days after your surgery, you need those smooth muscle cells to be proliferating. They're not going to be having such as a contractile force, but they need to proliferate to bridge that gap, really, to make it so that it can fully integrate into your arterial circulation. But you want that to be transient. So I did say how that process of differentiation and de-differentiation is reversible, and this is where you need it to, they need to proliferate, need to increase the number of them quickly, and then need to switch that off. So after a week, that proliferation needs to have been reduced, and you need to be going back to more of a contractile function. And in neo-intimal hyperplasia, basically that bit there doesn't happen. So after your 7 days, you've still got that high proliferation, which is going to just make that lumen get narrower and narrower and narrower and narrower until it blocks. So the persistence of that physiological role becomes pathological. So if we look at how that looks, if we look at smooth muscle cell proliferation, the things that can cause that smooth muscle cell proliferation, we've got different growth factors which can cause that phenotypic switch. So examples that we've got here, we've got IGF, which is insulin-like growth factor. We've got transforming growth factor alpha, alpha-thrombin, interleukin-1 beta, which is an inflammatory cytokine, angiotensin-2, and endothelin-1, and they work to increase your blood pressure. But all of those things, they're secreted from any number of different cell types. So we've got the monocytes, the macrophages, the endothelial cells on there. You can also get them released from platelets. So all of these cell types which are involved in that recovery and disease process can release these growth factors which will induce that smooth muscle cell proliferation. The other thing that can do it is something called ischemia reperfusion injury. So if you get a blockage in a blood vessel, then the tissue downstream of that is starved of oxygen and it's starved of nutrients. And when tissue is starved of both of those two things, so oxygen and nutrients, then that's called ischemia. Okay, so all of that, the heart tissue that's downstream from that blockage has that ischemia. It's not getting the oxygen, it's not getting the nutrients or the growth factors, anything that it needs, and then that tissue dies. If you then open up that blood vessel and restore that blood flow, the influx of oxygen, the influx of growth factors, the influx of nutrients can actually cause damage as well. Okay, so although you need it for it to survive, that influx is going to cause some damage as well, and that's why we call it ischemia reperfusion injury. And that can trigger smooth muscle cell proliferation as well. And then the final thing that can trigger smooth muscle cell proliferation is pressure. So if your blood pressure goes up, or if you have that high pressure wash, that can activate your endothelial cells to produce basic fibroblast growth factor. And what that will do is it will cause your smooth muscle cells to dedifferentiate. So there's all these different things from the cell types that are involved during the disease process and in the repair, from the repair process with your ischemia reperfusion and your high pressure. All of those things are going to trigger your smooth muscle cells to dedifferentiate so that they can try and make that vein look more like an artery. And what that looks like in the vessel itself, if you look, this is our normal blood vessel. We've got a bit of an endothelial cell loss there. And what happens is your smooth muscle cells underneath those endothelial cells start to proliferate so that the endothelial layer is then going to move inwards and it's going to become thicker. And that's because of your growth factors, your ischemia reperfusion and your pressure. And also with the different treatments that you have following bypass grafting, you're more likely to have heparin, nitric oxide and fibrinolysis. So these are blood thinners basically to prevent your blood clots from forming, but they can also contribute to this pathological process. So it can contribute to thrombosis as well. So that's thrombosis and neointimal hyperplasia. Atherosclerosis, we don't really need to talk about that much because we've just talked about it for an hour. So you don't need me to repeat myself. But you can see how your atherosclerotic plaque can cause that blockage of your blood vessels. After you have a vein graft, and if you do develop atherosclerosis in the grafted vessel, so in the vein that's been grafted in, it does tend to have particular features which are different to what you'd see just in a normal arterial circulation. So the atherosclerotic plaques, instead of being focal and just in one or two places, they tend to be throughout the graft. And they do seem to have a very poor fibrous cap, which means they're more prone to rupture. And they also have less calcification as what you get in the arterial atherosclerotic plaques. And that calcification is where I mentioned about the osteogenic smooth muscle cell phenotype, where they get crunchy. So you get less of that, but you do get that poor fibrous cap, which means that you're more prone to rupture. And atherosclerosis is the main cause of graft failure between 1 and 10 years, because it takes time to develop as well. So, just a quick recap on smooth muscle cells. So the things that I want you to think about, what are the major smooth muscle cell phenotypes? So what different types have we talked about? Which ones are in a normal blood vessel? What's that phenotype called? Contractile, yeah. So your contractile smooth muscle cell is your normal smooth muscle cell. What about when it's in an atherosclerotic plaque? What does that become? Synthetic, yeah. What about when it starts to take up cholesterol? What's that? Foam cell, yeah. What about when it starts to get crunchy? Yeah, calcified osteogenesis. different smooth muscle cell phenotypes. How do they behave? So what does a contractile smooth muscle cell do? Contract and relax. Does it like to grow? Does it like to move? It just wants to sit there and be left alone, contract and relax, get on with its job nice and quietly without any fuss. What about a synthetic smooth muscle cell? What does that do? Proliferate, so it grows more, yeah. Doesn't contract as much, yeah, because it's too busy growing and migrating. It likes to move as well. When are they beneficial or detrimental? So when would you want a synthetic smooth muscle cell? Yeah, definitely when you're during development. Yep. What about in an adult? When would you want a synthetic smooth muscle cell?
Injury.
After an injury, yeah, because that's what's going to heal that injury to your blood vessel. Your smooth muscle cells are going to have to grow then, because otherwise your blood vessel's just going to leak. And when else are they beneficial? What about in atherosclerosis? Are they ever beneficial in atherosclerosis? What about when you want that stable plaque? Yeah. So synthetic smooth muscle cells during atherosclerosis, although they're part of the problem, they can also be beneficial in that they keep that atherosclerotic plaque stable, much more less likely to rupture. Alright. So the last one I'm going to talk about is failure to integrate, because this is some of the work that we've been doing. I always talk about it being a confused smooth muscle cell. So failure to integrate, we're looking at these key areas here. So there's these joins basically. Yep.
Are stable plugs easier to treat if we identify them?
Yes. So a stable plaque, you'd be able to, if it did start causing clinical problems, you'd be able to use stenting for that, because that's just going to be opening up your blood vessel, but you're not underlying it, it's still going to be stable, it's not going to rupture. So yeah, if you're going to have one, have a stable one. Yeah. Right. So failure to integrate, I mentioned it's going to be focusing at these points here. So this is where you get that kind of join like that. And you can imagine if you've got a join like that, your smooth muscle cells that are in here are going to have to migrate and proliferate and change their phenotype to be able to integrate and to make that join solid. If you think about it like with if you're welding pipes together, you want a nice strong weld, and so your smooth muscle cells are going to have to de-differentiate first to be able to do that. That site where they attach is called an anastomosis, and I really struggle with saying that word as well, so that's the only time I'm going to say it. So there, we've got our vein and our artery, and we need to make sure that this bit here and this bit here gets that nice strong link. And so your smooth muscle cells there, the ones that are in the vein, they're going to be contractile. You're going to need them to become synthetic to be able to migrate and proliferate, lay down kind of the matrix that you need to have there to keep your cells nice and solid and in place. So that's what you need them to do. But we mentioned earlier that the factors that promote de-differentiation, we've got the growth factors, the ischemia, reperfusion, and the pressure. And what they all do is they trigger different pathways in your smooth muscle cells. So the different pathways that they trigger in your smooth muscle cells, we've got ERK, which is extracellular signal regulated kinase. It's normally you get like ERK1 or 2. Some of you might have looked at that during your projects. It's quite a common pathway to look at. And what ERK is it's a pathway that promotes growth. You've got P38, which they're related to the ERK pathway, but it's slightly separate, and that's more to do with cell survival. You can see why you'd need that. You get ROA, which is, I have an interesting relationship with ROA. Sometimes I love it, sometimes I hate it. ROA is a small G protein. It does a lot of things, and it does a lot of things in different ways if you're in a different disease or in a different cell type. It makes it really complicated to look at. And then you also get remodeling of your actin cytoskeleton. So that's these fibers here, which you can see running across the cell. They're the ones that cause your cell to be able to contract and relax, and when we de-differentiate, we lose those. And there's lots of different pathways that are activated. And for your smooth muscle cells to be able to behave in the most appropriate way, all of these need to be working properly. For your smooth muscle cell to be able to know when to dedifferentiate, when to redifferentiate, all needs to be done under, they all need to be working in harmony to be able to get that working properly. And we all know that very little of the time everything works in harmony. So this is what we talked about before with the contractile and synthetic phenotypes. So we've got the contractile with the contraction and low turnover, the synthetic with the disease or injury, and then you've got the markers. So the contractile ones are smooth muscle myosin, heavy chain and actin 2. And then you get KLF4 in your synthetic. And what we find with the smooth muscle cells after bypass is that in certain conditions such as diabetes, they exist somewhere along here. So they're somewhere among this phase in between the two of them. And because of that, it can be very difficult for a smooth muscle cell to know which way to go. Yeah. And so that's what I look at in the lab. So what we've found with patients who've got type 2 diabetes, if I get their blood vessels in the lab, I can grow the smooth muscle cells from them. I can do that from patients who don't have diabetes as well and compare them. And what you find is that patients with type 2 diabetes are much more likely to need a graft, but the graft has got a higher failure rate. And so we're trying to look at why that might be, and we're looking at the smooth muscle cells to be able to look at that. And what we found is that the type 2 diabetic smooth muscle cells, they're inherently different to non-diabetic smooth muscle cells. So when you get them in the lab, you can tell by looking at them if they're from a non-diabetic donor or from a diabetic donor, because they look different. So you can see here, these are smooth muscle cells which are grown in the lab. So here we've got in the ND, which refers to non-diabetic, you can see they've got this spindle shape, which facilitates that contraction and relaxation. You can see how they'd all bundle together to form a nice strong wall in a blood vessel. But the ones that we get from the patients who've got type 2 diabetes, you can see here they're really different. So now they're a lot flatter, which means they're more difficult to see, but they're also much bigger. So if I trace around that one, for example, you can see how much bigger it is. So it's lost that morphology, that spindle shape, which means it's going to be a lot more difficult for that to bundle together into a blood vessel wall. If we look at how they grow, so these are some growth curves. We've got the non-diabetic one of the open circles here, so that's how much they grow over the course of a week in a tissue culture dish. With the diabetic ones, they actually grow less fast. So they grow more slowly, but they're not able to do that dedifferentiation and repair as easily. And if we look at the cytoskeleton of them, so these are zoomed in on the smooth muscle cell, so this is just one smooth muscle cell here. The red staining is your actin cytoskeleton. And you can see in the diabetic ones, those actin fibers are going all the way across the cell. Whereas in the diabetic one, you can see already how much bigger it is. But look how different those fibers look. Yeah. But look how different these fibers are. They're really truncated. They look kind of like starbursts. And you've got areas where they're kind of all combined together, but they're not making a fiber. So this can start to show you how it loses that ability to contract as well. And so you can then map this onto how that looks on the phenotype, which we'll do at the bottom of this next slide. If we look within the cell, so that was looking at the cell as a whole. If we look within the cell, we get a reduction in the amount of RhoA that's there. So I mentioned earlier on about how RhoA is one of the mediators that you need to be able to work properly and in harmony with everything else to be able to know when you're going to differentiate and de-differentiate. And we get this reduction in RhoA.
There's actually a significant difference between type 2 diabetic patients and non-diabetic in terms of the expression of LRR.
There is, yeah, so we'll go on to that one, yeah. So the other things that we look at with the phenotype, you remember I mentioned smooth muscle actin. So smooth muscle actin, we get an increase in the expression of smooth muscle actin at mRNA. We also get it at protein, which you can see the Western blot there. And then the other thing that's down here, these are microRNAs. So I don't know if you covered microRNAs in medical genetics. I don't want to re-traumatise you with talking about that. What I will say is that microRNAs, how they work is they'll bind to particular messenger RNAs and prevent them from being translated. And what we find is in the diabetic smooth muscle cells, you get an increase in MER143 and 145. They both target KLF4, so they can switch off KLF4. The recent work that we did last year, says unpublished, but it's published now. We get a massive increase in MER17 and MER130 as well. And yeah,
Will they have something to do maybe with their with their structure?
they could be, yeah. We're doing some work at the minute. Some of your colleagues in the audience have been looking at what MER17 and MER130 is. But what we see if we map that onto what we know about our smooth muscle cells. So type 2 diabetic smooth muscle cells, they're rhomboid. They lose that spindle morphology, which is what you'd expect to see in a dedifferentiated smooth muscle cell. They have a low proliferative rate, which is what you'd expect in a contractile smooth muscle cell. They have a truncated cytoskeleton, so they don't have those fibres that allow them to contract, which is what you'd see in a dedifferentiated. They have reduced Rho A, which you see in a dedifferentiated, but they have increased smooth muscle actin. They have increased MER143 and 145 and reduced KLF4 because of that, which is what you'd see in a contractile smooth muscle cell. So you can see from this how the smooth muscle cells from patients who've got diabetes, at that key point after you've just implanted that vein, when you need to have that proliferation and migration within 3 days to rebuild that weld, to weld that blood vessel together, and then you need to switch it off. How are they going to be able to do that when they don't know which phenotype they already are? And so I think this is one of the other key reasons for early graft failure, is because you get that failure to integrate properly because these smooth muscle cells are in a state which doesn't facilitate easy switching one way or the other. So that's what we've got there. So you've got difficulty in phenotypically adapting to the changes in the environment, and then you get your vein graft failure due to lack of integration. So that's a very small amount of the research that I do. Like I said, I've been researching this for a long time. And I'm still carrying on with researching this at the minute. One of the things that's been interesting about this is at the beginning of this section when I talked about the graft failure rates between IMA and saphenous veins. For some of the patients, we've been able to get the internal mammary artery and the saphenous vein from the same patient. And if you look at those with diabetes, the saphenous vein smooth muscle cells, they change just like what I've shown here. Internal mammary artery ones are the same. So if you've got an internal mammary artery smooth muscle cell from a diabetic patient or a non-diabetic patient, you can't tell the difference, which might be why the IMA graft is much more successful than the saphenous vein graft is. Yep.
So why does the type 2 diabetes actually cause that morphological difference? Do we know why it causes that change?
That is what keeps me awake at night, that and my son. So that's what we're researching at the minute, trying to figure out what it is that triggers it. One thing that we do know is that it's not glucose. It's not glucose that does it. And the other thing that we know is that it's going to be epigenetic in cause. Because if we take these smooth muscle cells, when we grow them in the lab, we grow the non-diabetic smooth muscle cells and the diabetic smooth muscle cells in exactly the same media. So there's no changes in glucose between them, there's no changes in insulin between them, but that phenotype will stay there. So it's retained, it's got that metabolic memory that whatever has happened in that cell to switch it into that confused phenotype persists after you take it out of the body, which means that it's epigenetically regulated. So that's what we're trying to figure out. The MER145, we looked at DNA methylation, it wasn't that. That was such a pain in the bum to research. It took forever and it was a nightmare to publish because it showed that it had no effect. It's much harder to publish a negative effect than a positive effect, but we managed it. So we're still trying to figure out what that is. So watch this space. Yeah.
The research is ongoing for type 2 diabetes. Type 1 is not the same thing.
No, type 1 diabetes has got a different cause to it, and the pathways are also different. Yeah. I'm looking at gestational diabetes as well at the minute, because we know that the smooth muscle cells that we get from these patients, some of them have had diabetes for 20 or 30 years, so you don't know how long it takes for that switch to happen. With gestational diabetes, women have that for a maximum of 9 months. So we've just got some MRC funding now to be able to look at the smooth muscle cells in those patients to see if 9 months of diabetes exposure is enough to cause that persistent switch. And early indications are that it might be.
Just a question about the arthroschlerosis. Once that starts to develop, then you can do to starts there and it doesn't go away.
So in the early stages, for people who are in their teenage years or in their 20s, your body can repair. You can repair it to some degree and start to resolve that kind of fatty plaque. But the older that you get, then the less your body is able to do that.
Would that repair be done by healthy diet and exercise?
Yeah, and just by your body's own natural repair systems. Yeah. Right, I'm going to stop there for this. Just if you've got any questions about biological disease, about the assessment, you can ask them now.